Morning, Thursday, July 9, 2026. We're streaming live spine surgery here from Duke Spine Institute. Our patient presents from the Carolinas, North Carolina. He had a laminectomy done years ago. He's had a fusion done at L5S1. He now has adjacent segment disease, degenerative disc disease, spinal stenosis, herniations, bone spurs, disc osteophytes, causing pinched nerves and neurogenic claudication. Neurogenic claudication is the heavy, tired feeling you get in your legs after walking around. And what happens is you're standing up, you already have narrowing of the holes where the nerves come out from herniated discs. You make those herniations push back further, tighten up the holes, and pinch the nerves. So we're going to go in with a laser and get rid of as much of the herniations as we can at L23, 3445. Remember, L5S1 is already fused. We didn't do that. You got to lay still. No. If you have questions, feel free to ask us. In the meantime, we're going to go ahead and get started. Sean? Let's show the audience the 30 different causes of back pain for people. I'm Dr. R. Deukmedjian with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deukmedjian. Thanks for joining us. All right, those of you who watched the video can see that there are 30 very distinct and specific causes for back pain. This patient's main problem is not back pain. His main problem is actually his legs. He's got what's called neurogenic claudication, which is where the nerves are being pinched from herniated discs in the back, and he's already had fusion, did not like it, doesn't want more fusion. That's what they're going to offer him, is more fusion. He went ahead and had a laminectomy done, still has pain. Laminectomy is supposed to get rid of the leg pain, but it doesn't. Laminectomy is not a good surgery for spinal stenosis. It was originally developed by a neurosurgeon, Dr. Victor Horsley, and it was to take out a tumor from a patient's spine. It's a good surgery for taking tumors out, but this patient didn't have a tumor, and millions of people every year get laminectomies. They don't have tumors in their spine. They do it to decompress the nerves, but it's a terrible procedure because it doesn't work. And by the way, he actually had a fake laminectomy. Take a look at that. Go back to that AP view again. Hold on. Shot. We're going to show you the fake laminectomy he had. I hate to be the bearer of bad news, but take a look at this incision from here to here. That's a laminectomy incision. And now get an AP view marker. Take a look. He's still got his lamina. Just, I'll show you. Yeah, go ahead. You can see the white arrow. There's a lamina on the right side at L2. There's a lamina on the left side at L2. Then you got the L3 lamina on both sides. So basically, he's got spinous processes on lamina still there, even though they told him they did a laminectomy. I don't know what they actually did. But this is the kind of stuff we see all the time in spine surgery. Doctors scamming patients by providing them surgeries that aren't going to work, requiring the patients to come back, get more surgery because the surgery they did didn't work. That's not what we do at Duke Spine. Take a look at the screws and rods and cage at L5S1. So he's got a fusion with instrumentation at L5S1, and he's developed adjacent segment disease. He had a shaminectomy. We call it a shaminectomy when it's a scam or sham procedure. All right, if you have questions, ask me. But this is what you get when you go to most spine surgeons. They just cheat you. They do surgery that doesn't work. They bill your insurance. They make money. And then they know you're coming back for more treatment. That's not what we do at Duke Spine. We actually fix people's problems. So going forward into the future, it's important that people understand you have to choose wisely where you go for your medical care. All right, we're not doing an evocative discogram, but I'm still doing a discogram. We're going bilateral L23, L34, L45, going through the foramen, removing the herniations. Any questions?
Yes, we have a question from Lanu on YouTube.
Let me have a stylus. Yes, Lana.
Which hand do you use when holding the scope? Just curious if there's an advantage with left or right hand.
That's a great question. I'm ambidextrous. I forced myself because I was going to be a spine surgeon, a neurosurgeon. I needed to learn how to use both hands equally well. So I was really a right-handed person most of my life, but then when I became a surgeon, I switched to ambidextrous. I forced myself to learn how to use my left hand. So I can hold the scope with either hand. I typically hold it with my left, and I manipulate the laser with my right. Great question. All right, we're placing the dilator. You can see we're now at the back of that disc at L4-5. I'm going to go inside the tear, going right through the foramen. I'm going to get right into the herniation. So the nice thing about this surgery here is we're not removing any bone or ligaments, and we're going straight into the herniation, right where that's pinching the nerve. So we're going to be working right next to that nerve. Sean, take it out. Meaning that we're going to work right in the herniation. We're not going to damage the rest of the disc. We're not going to damage his lamina, his facets, his ligament. Complex joint. It's got multiple joints on top of each other, below each other, and they're all connected through discs, ligaments, facets. So when you start removing parts of your spine during spine surgery, that creates instability of the spine. And the instability then in turn creates back pain and pinched nerves and adjacent segment disease. So it's really important when you do spine surgery to try to do a surgery that doesn't remove normal structures that hold your spine together. See, spine surgeons do that with every spine surgery they do, unless they're doing the transforaminal surgery I do, which almost no spine surgeon does because it's too difficult. So to remove a cage and a rod. The answer is yes. I have. And in the past, I've done it if it's necessary and it's going to help the patient. But a lot of patients come to me with screws and rods and cages that they had put in elsewhere. And they say, Dr. Deuk, I'm having so much pain. Will you take out the cage and the rods and screws? And I would look at them and examine them, and I would find the real source of their pain. And it turns out the real source of their pain was not this cage, screws, and rods. It had nothing to do with their old hardware. It actually was called adjacent segment disease. It was a problem with pain coming from a joint above or below their fusion, like this patient. So you don't need to take out their screws and rods, okay? I'm not going to take someone's screws and rods out, even if they ask me to, unless it's going to help them get better. If the screws and rods are making the patient worse, they're suffering because they're having pain or neurologic symptoms from the screws and rods, then I will take it out. It's easy to take out screws and rods. Cages are a bit harder, but still doable, okay? But if the patient's not having symptoms from their old screws and rods, I am not going to take them out because it's not going to make them any better. Therefore, I won't do it. I don't do surgery that people want me to do because they want me to do it. I do surgery people want me to do because I know it's going to make them better. So I have to be convinced that whatever surgery I'm doing is going to help somebody before I'll do it. Some surgeons are happy to do surgery on patients, even though it won't make them better, just for the sake of making money. I'm not one of those surgeons. Any other questions?
No questions.
All right. Scar tissue, once again, you guys, this is a story of scar tissue. Some of you may be asking, Dr. Deuk, aren't you inside the disc herniation? The answer is yes. Well, Dr. Deuk, why is there so much scar tissue inside the disc herniation? And the answer is because his body made this scar tissue trying to repair the herniation. Okay? People think herniated discs get reabsorbed. They don't. They actually turn into hard scar tissue. And that's what we're doing, is we're removing the herniated disc along with the hard scar tissue that's formed around them. What causes the scar tissue? The inflammation. Okay? If you've ever seen somebody who has acne really bad, they have inflammation in their skin, on their face, or on their shoulders. And that inflammation, if they just let it go for years and years, it turns the skin into scar tissue, right? Under the skin. You get all this real hard tissue. That's what this is right here. It's no different. I've been trying to teach doctors and patients about this for years, but people don't necessarily want to listen. The reason is because I'm one of the only people in the world that actually know this. Other doctors don't. So they're not signaling the same messages. They're not messaging the same as we are, because they don't know what causes these problems. Right? If you look up degenerative disc disease, you might find on the internet lots of sources saying nobody knows what causes degenerative disc disease. Duke Spine Institute knows. It's inflammation of the disc, chronic inflammation. Not, 1 week of inflammation, but years and years of inflammation happening right here in this disc. That's what causes degenerative disc disease. If you get your disc repaired at Duke Spine Institute, you can avoid that degenerative disc disease. You can avoid the disc from continuing to collapse. You can get out of pain, and you can preserve much of what's left of your disc. Okay? It's like termites in your house. If you ignore them, they're going to continue to eat the wood and destroy the wood. Eventually, your whole house is going to fall down. But if you get that treated early and you make repairs, then you save your house from the termites. We don't have big termite problems anymore like we used to. But years ago, 30, 40, 50, 60 years ago, they would import wood with termites, and they would build houses and buildings with that termite-infested wood. And nobody knew any better. Well, most people didn't know any better. I guess the builders may have known. And the house would be destroyed by termites. Okay, until everybody caught wind of it. And then there was a whole business of termite treating companies. They would come to your house, put a tent over it, and kill the termites with chemicals. Okay? Point is, if you don't stop the termites, they will destroy every bit of wood in your house. Any questions?
No questions.
Wait. All right. Let's show the audience the 30 different causes of back pain. I'm Dr. R. Deukmedjian with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Deukmedjian plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Deukmedjian. Thanks for joining us.
Welcome back. You can see from our video, we played it again because the first part of the surgery we had to end the stream and restart it due to an update to the software we're using. And I want to make sure you all could see the 30 very specific causes of chronic back pain. And if I took 100 people out there with chronic back pain, all 100 would have one of those 30 causes or more. The average patient has 4 causes of back pain. 4. Okay? Shot. And some of those causes we rarely see. For example, you have tumors of the spine. You have infections of the spine. We don't see a lot of tumors or infections. Okay? That's a good thing, because spine tumors can be very bad things, right? And thank God most people with back pain don't have tumors. They don't have infections. They have inflammation as the cause. from a bad disc. Hold on, let me see. So that's easy to fix. Inflammation is easy to fix. Tumors are not easy to fix. Infections are not. So tumors and infections and fractures account for less than 1% of chronic back pain in our experience at Duke Spine. We looked at 5,000 people. 5,000 people with chronic back pain. And we looked at their causes of back pain. The primary cause, the secondary cause, the tertiary cause. And we found that, Sean? We found that the vast majority, hold on, of patients, 85%, their pain was coming from a disc injury. A disc injury. We call those disc injuries herniated discs, bulging discs, ruptured disc, protruded disc, extruded disc, slip disc, degenerated disc. So any of those terms that you hear about, they're all the same thing. There's no difference, to be honest. Physiologically, there's no difference. There's not even a book that specifies what you call one versus another. They're all basically herniated discs. And in time, laser, the herniated discs, well, they get scar tissue built up. Thank you, Jordan. You're a good man. They get scar tissue built up around the herniation in the back of the tear. And as that build up, it becomes what we call a tumor. Tumor means an enlargement or swelling in your body. Tumor. Now, tumor is not the same thing as cancer. Okay? If you have a pimple on your face, well, believe it or not, it's a tumor because it's swollen, it's big, it's enlarged. So anything that gets bigger than it's supposed to be, like skin getting built up around a pimple, is called tumor or swelling, enlargement. Some tumors are cancerous, but the ones that happen right here where the herniation is, these are not cancerous tumors. These are just scar tissue built up. A little bit of calcium, a little bit of scar tissue, mixed in with granulation tissue and herniated nucleus pulposus. And what causes this is the herniated nucleus pulposus. Because once the nuclear herniation gets far enough outside the tear, gets into the outer half of the tear, your body's inflammatory system recognizes it, sees it for the first time, and attacks the herniation for the first time. So when you have a tear through the wall of your disc called an annular tear, and the herniation of the nucleus only goes through the first half. So from the inside to the middle of the tear, your body's inflammatory system will not respond. And the reason is there's no blood supply to the inner half of the annulus. The annulus fibrosus, which is a very special kind of ligament that holds your bones together, the inner half of the annulus has no blood supply. There's no capillary, no vein, no artery. And without blood supply, you cannot have inflammation. Inflammation requires blood supply. So the only tissues that can get inflammation are the ones with blood supply. So because the inner half of your annulus has no blood supply, you will not get inflammation when you have a contained herniation on the inner half of the tear. Does that make sense to you, Anthony?
Yeah, it makes sense, yeah.
If it makes sense to you, it probably makes sense to most people. So, inflammation requires vascularization or blood supply. All right, any questions?
Yes, we have a question from Pav on YouTube.
Hello, Pav on YouTube. Nice to meet you. Welcome.
Hi, Dr. Duke. Can you explain how pain stops instantly after DLDR, even after years of inflammation and pain?
Great question, Pav. You are correct. The pain in your back or neck stops instantly after this procedure. So why does that happen? Well, my friend, think of it like a zit on your face, a pimple, acne, whatever you want to call it, right? Once you pop that pimple, then the source of inflammation goes away, right? You pop that pus out, the bacteria squeezes out, the pus squeezes out, and guess what? There's no more pressure. The pressure is gone because a pimple, if you've ever popped one, you'll see that pus just squeezes out and shoots out, right? It shoots out because it's under pressure. Why is it under pressure? Because of the inflammation. The inflammation is creating a lot of interstitial fluid and pus, which is encapsulated in an abscess, a wall of scar tissue, and it's under pressure. So that pressure is putting pressure on your pain nerves that are there. And once you pop it, the pressure is gone and the stimulation of the pain nerves is gone. So that's really what's happening. I'm popping a zit in their disc. I love it. We're popping disc zits. You like that, Jordan? No doctor has ever described this as a disc zit in the history of medicine until now. But I think I might have said it years ago, but it's basically a disc zit. And think about it. When you have a zit on your face, that red pimple, and you take your finger and mash on it, or if your friend mashes on it, right, it hurts. Oh yeah, nice piece of herniation. It hurts. So think about this disc zit in your lower back, and you're sitting down on a chair and the pain gets really bad, right? Why does the pain get bad? Because the pressure on your disc increases to 2.5 times, 2.5, 250% higher when you're sitting down than when you're standing up. Okay, that's just the biomechanics of your spine. I don't make this stuff up, it's real. You can look it up. So pressure on your discs increases 2.5 magnitude when you're sitting compared to standing. Okay? So a lot of people with this disc pain, the disc zit pain, when they're sitting down, it just puts pressure, more pressure on the zit that's inside their disc. So I'm here popping their zits, and I'm cleaning them up so that it doesn't come back. You like that analogy? It's true. It's really what it is. See, the beauty of knowledge, knowledge is power. It gives you the power to understand things, problems, and then solve them. Once you understand the problem, you can solve it. I have one solution here, but the problem is nobody else understands the problem. Therefore, solutions are few and far between. This is one solution, and it works. Is there another solution for the disc zit? Maybe. But remember, it's not a zit because it's infected. There's no bacteria. What's causing the inflammation, unlike the zit in your face, where it's bacteria, what's causing the inflammation here is the herniation. So to get rid of the inflammation and the pressure, you must get rid of the herniation. Whereas with a facial zit, you must get rid of the bacteria. That's the difference. Right, Dr. Berndes? Yeah. Oh, Luis is doing a great job. I know. I got to mess around a little bit. Any other questions? Thanks, Pav.
No questions.
All right, well, we're cleaning out the herniation. We're almost done. We've already fixed 3, now 4 discs. We got 2 more to go. We're going to end the stream. We're going to then come back and show you a Deuk plasma rhizotomy for sacroiliac joint pain. Okay? Sacroiliac joint pain is one of the most common causes of lower back pain. It's probably, well, it's probably the third most common cause of back pain. And if I had to say it, I want you to understand the difference between primary, which is the main problem, and secondary. The primary cause of back pain in almost every human being and neck pain is a disc injury. This disc's it. Look at that inflammation right there. That's it. You guys see it? That's the tear, and it's full of inflammation. I've been telling my colleague neurosurgeons about this for 20 years, and they don't want to listen. But all you got to do is come in here and clean it with a laser, and the pain goes away. So that's part of the reason, too, is I'm getting rid of the granulation tissue, which is the pink stuff, with the new little painful nerve fibers that are in there called Class C type 4 fibers. Two different names for the same thing. So, just about done with this disc. There's a piece of herniation. I think this patient's going to be very happy. Remember, he traveled all the way from North Carolina to come here and have his back fixed because the doctors where he lives didn't know what was wrong or how to fix it. So we knew, and we're fixing it. Now, I will say this. When he got here, we found out that he also has pain in his hip joint from arthritis in the hip on the right side. So he was complaining of groin pain when I saw him yesterday, and I said, that's not coming from your back. That groin pain is coming from your hip. So I examined his hip, and I saw that he had horrible pain with rotation of the hip joint, which means arthritis of the hip. So we're going to send him out to get an MRI of his hip, and we're going to bring him back in the future and do his Deuk plasma rhizotomy to kill the pain in the hip. Huh? And he also has a piriformis syndrome, which we found on exam. He did not want to treat it today. I'm actually happy about that because with 6 disc areas to fix, that's like maximum of what we can do. And to start adding more surgery is going to take too long, and it puts the patient under anesthesia longer than I want them to be. Yeah, and when he comes back, we can do his piriformis and his hip in one shot. By the way, if you've ever had hip replacement surgery and you're having pain in your buttock, the reason is you have a piriformis syndrome, which is a torn piriformis muscle. One of the most common causes is hip replacement surgery, and your surgeon doesn't even realize they're doing it. But it's called iatrogenic injury. What it means is your surgeon tears the muscle while they're doing the hip replacement. So I had a lady yesterday I was talking to on Zoom where her buttock pain started after hip replacement surgery, and basically the surgeon accidentally tore her piriformis muscle. But the problem is once you tear the piriformis muscle, it never ever heals on its own. So it just keeps causing pain forever until you fix it. And there's only one fix in the world that really works, and that's the Deuk piriformis release that I pioneered. Look at that tear right there. You guys see the tear and the redness in it? That's the inflammation that I'm talking about within the annular tear. Now that we're in the outer half of the annulus, you're seeing more of that inflammation. That's where the back pain comes from. Just about done with this disc, and we've got 2 more to go. Any other questions, Anthony?
No questions.
Somebody asked me the other day, Dr. Duke, you said you learned the technique from the Israelis. I said, no, the laser is from the Israelis. The technique is my technique. I pioneered it. It's not from the Israelis. Though I've had several Israeli surgeons contact me and want me to teach them how to do the surgery. And they're in Israel. I have no problem teaching. Happy to do it. But we have a way of doing it. You have to contact us by email. Let us know you're interested. You will need financial support for your fellowship. It will be a year-long fellowship. You will need to have a financial support to pay for it. We don't pay you to come here and learn my surgery. I think a lot of people don't understand that. We don't need a fellow. We're not going to pay a fellow to come here. Fellow is going to pay us to come here. A lot of fellows are trained and taught surgery by a mentor, and the mentor benefits from the fellow because the fellow helps with patient care. They take call, they cover emergencies, they do surgery, and make a lot of money for the institution. We don't have that opportunity here for fellows to take call and generate money for the institution. So we have to do things differently. But you will need probably governmental support to be able to come to Duke Spine. If you're from a foreign country, I don't mind teaching foreigners. I'll teach anyone that's interested and appreciates. But there is a cost to the training and a cost to staying here for a year. But you have to be a doctor. So I'm not going to train someone who's not a doctor in their country. All right, we're done with this disc. We're going to move on to the next, and we have one more after that. Any other questions?
No questions.
That looks good. You're going to have to give him a little more medicine. Let's go. Jordan, come on in. Hold this. So we just did L4-5. Now we're going to be doing L3-4, correct, Luis?
Yes.
Then we have one more, which is L2-3. Shot. You can still see the guide wire. I'm sliding down the guide wire with my dilator. Look at the herniation there. Pretty big. I got this. You guys see the herniation in front of the dilator? Show them that herniation. Yep, right there. Hold on. Hold on. Let me see. Shot? Yeah. Perfect. 15 minutes left, Dr. Berndes, on this. And then we got the the SI. Huh? Well, you let me know. Let me know. Well, we don't have to if he's not safe. You just let me know as we get closer. Any questions from the audience?
We have a comment from Knight of Justice on YouTube.
Knight of Justice. I love the name Knight of Justice.
Yeah, it
Yes.
sounds cool. I am a patient of Dr. Victor, neurosurgeon in South Africa.
Ah,
I will definitely mention it to him about the training.
of course. I love South Africa. I've been there a couple of years ago. Actually, I think it was 2 years ago. Most beautiful country. I was in Cape Town. A lot of turmoil over there right now. I don't approve of the violence. I understand there's been a history there, but people, we live in a different era, and violence is never acceptable. Never. Never, never, never. All right. Thank you for the comments. So South Africa, anybody here been to South Africa? No? Someday. Someday. I really wanted to dive with the great white sharks. That's my life ambition when it comes to great whites. That's the only ambition you should have when it comes to great whites. Cage diving, okay? Do it where? Where? Oh, this is great whites. Great whites, you got to be in Africa, you got to be in Australia. But Africa is famous, especially Cape Town, because they have the Cape seals, okay? And the great whites eat the seals. So the seals are right there on the coast, and they swim in the water, and the great whites come and feast on them. So that's why you never want to put yourself in the water looking like a seal, because it won't end well for you. But I went there and was hoping to do a dive, and then they said we're canceling because the weather's not good. I guess they do that a lot, you know. But the weather looked fine to me. But anyway, who knows? But I do love Cape Town. I love South Africa. I went to Table Mountain and hiked it. It rained like crazy that day, but it was so beautiful. I wouldn't trade it for anything. If you like hiking outdoors, it's amazing. One of my favorite flowers comes from South Africa. It's called the Disa, D-I-S-A. It's a type of orchid. It comes from Table Mountain, actually, and it likes the climate there. Very wet, very cold in the winter. Would love to make it back to South Africa someday. Had my best haircut in my life in South Africa at the barber shop. And that's where I had my very first waxing of my nose and my ears. I got addicted. Okay? For, you know, guys, as we get older, we get these hairs starting to grow on our ears, and they drive people crazy. Like, they drive me crazy, just tickling me at night while I'm trying to sleep. So I decided I saw the sign, you know, when I went for my haircut, and it said waxing, men's waxing. It was a men's shop. I said, what do you wax? And they said, we can wax your nose, your ears. I said, really? Fine, give it a try. So they put this wax on, and then they literally rip it right off, and it pulls your ear hairs out and your nose hairs out. And I'm going to tell you something. That was amazing. I didn't have any more tickling, and I had the best shave. It was a straight razor shave in a barber shop. One of those old chairs. It took me about 20 minutes, but it was the cleanest shave I've ever had in my life. Yeah, I had a lot of fun in South Africa. And the wildlife is pretty amazing. All right, any other questions?
Knight of Justice said, Were the men all Turkish?
I don't know. Great question. They did look Middle Eastern. So maybe you're right. What is it?
Just trying to get the armboard came off.
What came off?
The armboard.
Let's get the light on, please, and get the armboard fixed.
You want to keep me real quick? Just so you can help Sam out. Keep me real quick.
Do we need Hector here?
No.
How did the armboard fall off? Were you just trying to adjust it? Oh, okay. No worries. Yeah, thank you. I think it's a great idea. Checking the ulnar nerves. Yeah. Well, when you're in the surrender position, you got to check it. Make sure it's padded.
You usually check it every hour, every 45 minutes. You got it, Jordan?
All right. So far, everything's going well. We're almost finished here, folks. It's been a long surgery. I get it.
Yeah. I just try to always put a finger under the ulnar nerve just to check it, and feel the pressure on my fingers. So,
Yeah.
sometimes I can't see it.
So this herniation on the right side at L34 is actually not so old. If you look at the consistency of the herniation, it looks like a newer type of herniation. It has more of the blue dye attaching to it, which is a good sign that it's newer, fresher. So if I had to guess, I think he's had some of these herniations for a long time, and some of them are a bit more recent. Probably very common. When you get a tear in your disc and you start getting herniations, remember they stick inside the tear and they hold the tear open, and more herniations start coming out. So then you just got this process over years of herniation after herniation after herniation coming out through the tear. Some are big, some are small. The bigger ones probably cause more inflammation and symptoms. The smaller ones, probably less.
Thanks, Jordan. Perfect.
All right, any questions?
No questions.
Just about done. Just a lot of scar tissue. All that white stuff there is scar tissue. All of it. I got to work on that scar tissue just a little more. This should be the end of it here. The gold color is calcium. Your body puts calcium down in areas where there's damaged soft tissues. That's why we're seeing it. It's called dystrophic calcification. That's the gold color you're seeing. It's integrated into the scar tissue. It's not by itself distinct. It's literally part of the whole mess that we're zapping out with the laser. How much power have we used, Jordan?
For this level, we are at 1979.
That's not much. 20 kilojoules for this level. How about so far in the whole surgery? Over 100, probably. Well over 100. 100 and what? 103? It's probably more than that. Yeah, 123. 123 kilojoules of energy. Laser energy so far. We got one more to go, so another 25. Wow, look at all that inflammatory tissue. Just so much. All right, we got about another 2 minutes on this disc, Dr. Berndes, then we're going to move on to the last one. Are we okay to proceed with the last disc? 6 discs, folks. That's a lot. I've never done more than 6 at a time. 6 is like once a year I'll get a 6. Yeah, he's a healthy guy, so he can tolerate it. Thank God. Any other questions, folks? We're streaming live spine surgery so that you guys can ask questions. We have betadine in there, right? Yeah. Just about finished here.
No questions.
Do you say no questions?
Yeah, no questions.
Thanks. Hector, we got about 5 minutes left on the discs, and then we're going to assess to see if we can do his SI. Depends on how stable he is medically. Okay, that should be it right there. A little bit of fat in the epidural space, so we know we're done. One disc left. We lose very little blood in this surgery. You need to put pressure here and wipe. It's the pressure that matters. He's probably lost about 10 cc's of blood. We put some staples in just to keep it from oozing overnight. We get him out in the morning when the patient comes back for a checkup. We put steri strips in. He's going to have a little more bleeding than normal for at least one reason, maybe two. I'm seeing the second reason right now. But the main reason is he's already had surgery. Remember, he had a laminectomy. Well, surgery creates scar tissue underneath your skin, around your spine. And that scar tissue, we just went past it to get to his disc. So he is going to have a little bit more bleeding than a non-surgery patient who didn't have prior back surgery. Okay? So we expect a little bit more bleeding from his scar tissue from his prior surgery. Any questions?
Yes, we have a question from Knight of Justice on YouTube.
Sure.
Will there always be small pockets of calcium in the inflammation?
Well, they're not in the inflammation per se. The calcium is in the scar tissue. So the scar tissue is not really inflammatory tissue. It's scar tissue. It's what the inflammation leaves behind. So the inflammation is going to leave behind scar tissue. Your inflammatory response has different phases, like 3 phases, maybe 4. And the first phase is it sends in the neutrophils, which are the soldiers with the grenade launchers and tanks and AK-47s. They just shoot everything up. That's what neutrophils do. They destroy everything around. They release these enzymes or chemicals that just destroy anything biological, bacteria, fungus, parasites. And then after they're done destroying, your macrophages come in and clear out the rubble. They're like bulldozers and excavators. They just clear out all the rubble. Yeah, they're like Pac-Man. They come in and just clean everything out. And then you get fibroblasts, and you get these fibroblasts and endothelial proliferation and little new nerve fibers growing in. So you start to rebuild. You have a rebuilding phase, okay? So that's really the phases of inflammation and repair. All right? So the fibroblasts lay down scar tissue. They're the rebuilders. Now they can't rebuild with muscle. They can't rebuild with bone. They only rebuild with scar tissue, which is collagen and elastin, mostly collagen. That's why scar tissue is made out of collagen. All right, collagen. But the good news is the annulus fibrosus is already made out of collagen. So what you're doing is you're replacing the old collagen with new collagen. So it's one of the few tissues in your body that actually get repaired by your inflammatory system properly, but only after you remove the herniation and do the debridement. Now the inflammation can never get rid of this nucleus pulposus because, number one, the nucleus pulposus is really weird stuff. It just doesn't die off. It doesn't get destroyed and removed. It stays there. You know? You've all heard of acid. Acid can chew through metal, and it can chew through wood. Just destroys everything. But it cannot go through glass. Glass is impervious to acid. Glass is acid's kryptonite. Acid is kept in glass jars, okay, because it cannot destroy glass. So the herniation is that thing that the inflammatory system cannot destroy or remove. Therefore, it keeps attacking like a mindless zombie, just attacking your herniation but never getting rid of it. And what that does is it causes massive destruction around the herniation, scar tissue, and then eventually calcification and neoneurulation and neovascularization. You get all these new blood vessels and nerves. But you never fix the problem. So your body just keeps fighting this foe that it can never defeat or get rid of. And people say all the time, Dr. Duke, I read on the internet that your body will clear out the herniation. I got 3 minutes left, Berndes. Can we do the SI? All right. So we're going to end the stream in about 3 minutes. That's why the Duke laser disc repair is so special, because we're helping your body clear out the source of inflammation, the herniation, plus we're getting rid of all the scar tissue that's pushing on the nerves, causing your legs to go weak and numb at the same time. Okay? It's a one-of-a-kind procedure. And I pioneered it, I developed it, and it's only available here at Duke Spine. All right, I need a grabber. So the reason we have a little more blood on this side, that's what you're seeing, is because we already did the other side, remember? And so the blood is actually coming through this degenerated disc right through the center from the left side over to this right side, just tracking through. Because I already did the other side. So it's still bleeding just a little bit, like a little ooze. Now remember this laser fiber, laser on. The laser fiber is only 1 millimeter wide to give you perspective. And the endoscope is so advanced in terms of high definition, high magnification, that sometimes I can actually see individual red blood cells. Like on a really nice case, I could see a little capillary that's ripped, and I can actually see red blood cells coming out of that capillary. It's pretty amazing. I've seen that before. All right, just about done. This is the last bit right here. Wait. I'm going to set it up, and then we're going to clean it with the laser and we'll be done. There it is, the last bit right there. Any other questions before we end our stream?
We have a comment from Paul Thomas on YouTube.
Yes, Paul. Happy to take your comment.
I hope that the patient is stable enough that the doctor moves to the SI joint. Quite interested on what lasers can do in the SI joint space.
Thank you. Yes, Dr. Berndes has given me the green light. We're going to wrap this up. We're going to end the stream. We'll be back in a moment. And by the way, we don't use the laser on the SI joint. We use plasma energy. Totally different type of energy, radio frequency energy. Okay? But you'll get to see it in just a moment. All right, we're pretty much done here. Thank you for joining us. Just the last 30 seconds. And I've zapped away all the herniation there that's been pinching his nerves. We're also treating the back pain coming from the disc, but we're done. We'll be back shortly to do our sacroiliac joint. And then he'll probably come back in a year or so and get his hip done, as well as his piriformis.